I think we'll start. Louder? Oh, okay. Can you hear me at the back? Good. Someone waved. Thanks a lot. Anyway, good evening. Thank you for coming. And it's wonderful to see so many people here. I think this is a wonderful event that we're doing because I have to tell you that although I'm intimately involved in the healthcare system, I find it very complicated. And if I find it complicated, I think you'll find it complicated. And it's in midst of change. So my name is Dr. Peter Zalan.
Bonsoir, moi je suis Kim Morris et moi je suis doyenne de l'École des sciences de la santé au Collège Boréal. Bienvenue à cette discussion importante intitulée « Concevoir un système de soins de santé mieux adapté aux personnes âgées », le deuxième sommet sur la santé présenté par Horizon Santé-Nord.
I don't know what she said, but it's correct.
Sounded good.
Welcome to our public forum, Designing a More Seniors-Friendly Healthcare System. And this is the second summit organized by Health Sciences North. This past March was our first summit, Designing a More Seniors-Friendly Community, and we had close to 300 people attend. We want to follow it up with a discussion about how to make the healthcare system more user-friendly and effective for seniors and their families. Specifically, we want to talk about how patients and their families can have a greater voice in healthcare.
Au-delà de 300 personnes ont participé à la première conférence en mars dernier qui était intitulée « Concevoir une collectivité mieux adaptée aux personnes âgées ». Nous avons donc voulu poursuivre la discussion de comment arriver à un système de santé qui est plus facile à traverser et qui est plus fonctionnel pour les personnes âgées et leurs familles. Plus spécifiquement, nous voulons discuter comment les patients et leurs familles peuvent avoir une plus grande voix ou peut-être on pourrait dire un plus grand impact sur leur système de santé.
So you may have noticed, coming in, that there's a number of vendors and exhibitors here, and they're part of HSN Seniors Fair, which is a new element to this summit. We not only wanted to talk about how to improve healthcare system for seniors, we want to give you an opportunity to learn more about the goods and services available for seniors and their families in their community. And we also want you to have your say tonight as well.
Nous sommes heureux de pouvoir vous offrir différentes options d'information ce soir. Vous avez plusieurs kiosques d'information et d'exposants qui font partie de la foire pour personnes âgées. Nous ne voulions pas simplement vous parler des améliorations possibles. Nous voulions vous donner la chance de voir quels services et produits sont disponibles dans notre communauté pour vous et vos familles.
So just a couple of words about our format. The forum is divided into two. In the first half, we'll begin with a few words for someone who's experienced hospital care firsthand. We'll then hear from our first keynote speaker and follow with a question and answer period. Then we'll take an intermission to give you time to visit the information booths.
Il va y avoir deux parties à notre forum ce soir. Premièrement, vous aurez la chance d'entendre un témoignage d'un individu qui a vécu l'expérience de notre système de santé personnellement. Nous aurons ensuite une pause durant laquelle vous aurez la chance de circuler et de visiter les kiosques d'information. Suite à la pause, nous aurons deux autres conférenciers suivis d'une période de questions. On vous demandera d'utiliser les micros situés un peu partout pour la période de questions et vous pouvez poser votre question en anglais ou en français.
I understood that. After the intermission, we'll hear from our two keynote speakers and then have another question and answer period. And we have a microphone set up in the aisle, and you can make your way to the microphone during our question and answer period. So let's begin. Kim Fahner is a member of the CEO Patient and Family Advisory Council at HSN. This council reports directly to the CEO, Dr. Denis Roy, and is responsible for providing feedback and recommendations on how to improve hospital-based care for patients and their families.
Madame Kim Fahner est membre du Conseil consultatif des patients et des familles qui a été mis sur pied en 2012 par le directeur général, Dr. Denis Roy, et qui se rapporte directement à lui. Ce conseil donne une voix à la communauté en donnant de la rétro et en faisant des recommandations à Dr. Roy quant aux améliorations possibles au service d'Horizon Santé-Nord. Madame Fahner va nous partager quelques-unes de ses idées sur la conception d'un système de santé mieux adapté aux personnes âgées.
So, we've invited Kim to share her insights on how to make healthcare more seniors friendly. So, welcome, Kim.
Hi, everybody. First of all, on behalf of the Patient and Family Advisory Council, we wanted to extend our sympathies to the families at the hospital for the loss of the 4 healthcare workers from the orange crash on Friday. I am here as a member of the HSN Patient and Family Advisory Council to share my story with you. For most of my 30s, I was the main caregiver and advocate for both of my parents, who spent their last years dealing with serious health issues. In 2001, my father had a major heart attack and open heart surgery. My mother faced the same crisis in 2004. She had smoked most of her life, so when in 2008, she had what she thought was gout in her right foot, we hardly imagined that she had peripheral artery disease and would end up with gangrene. In April of that year, she had an amputation of her right foot, which left her bedridden until her death of congestive heart failure in December of 2008. I was the main caregiver as my sister lived in a different city. The extent of her physio in 2008 was 1 or 2 photocopied sheets of exercises given to her by CCAC to do at home. That was the physio. It was, quite simply, not enough to get her on her feet. She dealt with depression throughout that last year of her life, confined to her bedroom and without hope. After her death in December 2008, my father struggled with poor eyesight and diabetes. In August of 2009, he went on a fishing trip with friends. He fell, banging his head and neck on a rock. He was airlifted out of the bush to Blind River and waited there for 16 hours on a striker board because there were no beds available in Ontario or Quebec. The osteoarthritis in his neck had fused the discs of his spine together, so he lived because of that protection, but actually became paralyzed as a result of the fall. He was then flown to Northern Michigan Hospital in Petoskey, Michigan. He had excellent care. There were no complaints, including a spinal surgery to remove bone fragments and relieve pressure on his spine. But the point I want to make is that our system failed him. He stayed there about 2.5 weeks. It should have only lasted 1 week, but there were difficulties in the liaison process between the States and Ontario, even though we're so close to Michigan. My sister and I needed to lobby our MPP and appeal to local Sudbury media. So the Northern Life and Sudbury Star were stellar at that. We should have known that this would be the beginning of a very difficult journey for us all. The bills from Dad's 2.5 week stay, because of lack of beds in Canada, add up to just over $100,000 American, and I forwarded all of them to OHIP because I couldn't afford to pay them. No, they had to pay them. Dad returned to Sudbury in late August 2009. He was now characterized as a complex quadriplegic at the age of 76. He often said he wished he could kill himself and could not imagine living his life as it now presented itself to him. He entered into the rehab program at the hospital here in Sudbury, but was transferred to Lyndhurst, which is part of the Toronto Rehab Institute, in October of that year. They did excellent work, but he did not improve physically. Dad stayed there from October 2009 until February 2010. We often drove down to see him on weekends. Upon his return to Sudbury in February 2010, he was told he needed to go from the hospital to a different place. He was transferred to St. Joe's CCC in June of 2010 and stayed there for a year, all the while wondering and worrying about where he would go next. The constant shifting from institution to institution wore him down physically, mentally, and spiritually. That 1.5 years in long-term care was challenging. Snacks like cheese packets were dropped off, but it seemed as if staff had forgotten that my dad was paralyzed and could not open these items. Simple things like offering to refill water glasses, too, became something that we had to fight for as a family. It meant that we had to be there for as many meal times as possible to ensure his best care, even though my sister and I were both working full-time. It was like having a second full-time job with no support for caregivers. I learned how to advocate for my father, as he often said he didn't want to bother anyone. While many will say that our frail elderly need to learn how to advocate for themselves, I believe there is a marked generational difference in the ways in which we approach our healthcare professionals. At St. Joe's, Dad had the ability to continue with physio, and that was a good thing, mostly for his spirit and sense of independence. It was there that I learned to become what the nurses called my dad's terrier. It's not most flattering, but I'll take it. I spoke up, raised my voice, asked questions, all to figure out what I could do to ensure that my father had a decent quality of care. What of those who didn't have daughters or sons, I often wondered. In June of 2011, Dad was declared an ALC patient and moved into Pioneer Manor. He lived there until mid-September when his health began to fail. He loved that place as a home, listening to music in the lobby and making friends. In fall of that year, he had a heart attack and double pneumonia. He was rushed to ER at HSN and wasn't expected to live through the night. He surprised us and lived through the night and into the next couple of months. The damage was done, though his heart was broken. He stayed on 6 South at HSN until he was declared palliative in early November. While there, the hospital tried to discharge him. I understand the Home First initiative, but there needs to be a more seamless and transparent process for patients and families, and consideration of the very complex cases. I argued that if the hospital discharged him, he would only be brought back in to emerge the very next day. At this point, air was gathering in his belly so that he looked pregnant, which was disturbing. He was hallucinating and could not keep food or water down, and they wanted to discharge him. He had a catheter in his bladder, one up into his bowel, as well as a tube down his nose to pull air out of his body. His nurse finally advocated on his behalf because we kept referring to his obvious poor state of health, and Dad was allowed to stay rather than be discharged. He was meant to have had bowel surgery, but his heart was too weak, and so on the morning he was slated to have life-saving surgery, he was declared palliative instead. There was delay after delay that morning, and he suffered mentally in the waiting for news. Finally, somebody came to tell us at 11, hours after his scheduled surgery time. He was moved to palliative care in mid-November. While he was at the hospital, he was under the care of an excellent hospitalist. She went on a break for a few days, and we encountered a replacement hospitalist. That new replacement hospitalist told my sister and myself that my father was no longer palliative and could return home to Pioneer Manor. We wept, so frustrated by the system, and asked her if she had fully reviewed and read his chart. She admitted she had not. We prevented her from telling our father that he was not going to die. We had to protect him from this news because we knew it was not true. He was palliative and he was fading. After she fully read the chart, she agreed that she was mistaken. Can you imagine the mental torture our father would have had to undergo if he was told he wasn't palliative? All he wanted to do was go home to Pioneer Manor to live, and she would have given him that false hope. He was preparing for his death, so we had to stop her from falsely informing him he was better. 2 weeks later, he died. He had been truly palliative after all, as we knew. What have I learned about the system in my time within it as a patient advocate for my parents? I have learned that healthcare providers need to be more aware of the patient's own humanity. I would ask that doctors walk into the rooms of their patients thinking of their souls as well as their bodies. They are usually fearful, in pain, terrified even. If doctors could consider how they would like their parents to be treated at the end of their lives, perhaps that would help. I understand that they have seen many people die, but each person is beloved, is cherished, and deserves at the very least dignity and respect. I would ask that there be more clarity in the communication process between doctors, nurses, and family members. It shouldn't be as exhausting a journey as it is for either the patient or the family. It should be clearer, more efficient, and simply kind. I would ask that we remember that not all frail elderly have sons or daughters to care for them at home, and that those who do have caregivers who need to be connected to organizations that can support their mental health as well. I hope, in speaking to you of my journey, of my parents' endings, as a family member of a patient, that we can make weaknesses into strengths so that other families do not have to undertake the same exhausting and painful journey that I did. I hope that other sons and daughters with parents in their final days have less of a struggle than my sister and I did. I hope that there is a growing sense of awareness that the elderly should be valued and supported in our society. We owe them that much at the end of their lives: some peace, some kindness, some consideration. We would, I'm sure, want the same for ourselves. Thank you.
Thank you, Kim, for sharing your first-hand account of how the healthcare system, or didn't, work for you and your family, and how we should improve it.
Notre premier conférencier, Dr. Sholom Glouberman, est le fondateur et président de l'Association des patients du Canada. Dr. Glouberman a fondé cette association suite à ses expériences avec le système de soins de santé, premièrement comme aidant pour son père et ensuite comme patient. Son livre intitulé My Operation encourage les patients et leurs familles de prendre contrôle de leur santé et de questionner le système. Our first keynote speaker is very familiar with the healthcare system as an advocate, a family member, and as a patient.
Thank you. Dr. Sholom Glouberman is the founder and president of the Patients Association of Canada. He formed the association in 2007 following his own experiences with the healthcare system while caring for his father and then as a patient himself. He wrote a book called My Operation, in which he advocates for patients and their families to take more control of their health and ask questions of the system. Dr. Glouberman is the philosopher in residence at Baycrest Center for Geriatric Care in Toronto, and he brings a wealth of professional and personal experience to the topic of designing a more seniors-friendly healthcare system. Please welcome Dr. Glouberman.
Thank you. Thank you very much for inviting me, and it's an honor to be here, and I've had quite a day meeting people and trying to understand how much the hospital here is trying to begin to engage with patients and have patients participate in order to change things. So it's quite an honor to be here, and I'm looking forward to the rest of the evening. I'm supposed to use this to change things, but it's not. Oh, there it goes. Okay. Begin by disclosing that the Patients Association has received funds from many different organizations and does not take funds from drug companies. That's what that slide shows. I'm going to start off by talking about the history of the healthcare system that we have and explaining a little bit about how we've come to be where we are. Our healthcare system really started in about 1850, were the early stages of the change in healthcare. Before 1850, most people lived to the age of 35 or 40. The average longevity of people was between the ages of 35 and 40, and largely that was due to the fact that many children and infants died very young, and many young women died in childbirth. If you lived to the age of about 20, then you could live to about 60 or 70. But the average lifespan of most people in what we now call the developed world was between 35 and 40. And that lasted up until about 1850 when things began to change. Some of the changes that happened after 1850 include, first of all, the introduction of ether so that you could have surgery with people feeling no pain, and then the introduction of cleanliness so that people wouldn't die of the infection after surgery. And finally, in 1880, they began to discover the germs that caused infectious diseases, that caused most people to die at that time. And with the discovery of the causes and the course of these diseases, we began to have a modern healthcare system. So after 1880 is when most of the hospitals and most of the medical schools, the professionalization of doctors began to occur. And we have a healthcare system that we now recognize as the system of today. It's a system that's about 130 years old. It's not much older than that. It's a system that's the system that we face. What happened between that period and now is that there was a tremendous decline in the percentage of population that died of acute infectious diseases. So the system was very successful. All the infectious diseases that used to occur have largely disappeared. So there is no more smallpox. The number of people who've died of tuberculosis has dropped dramatically. Typhoid fever and cholera are very rare and happen in other places, not in the developed world, and so on. Those changes were amazing. I mean, an amazing change in the nature and structure of disease, and a dramatic increase in longevity from 35 and 40 to now longevity in Canada of over 80 years. In Canada, what happened was that our healthcare system, the modern, current, publicly funded healthcare system, really focused on those aspects of the system that had changed. So in 1947, Saskatchewan began a process of hospital insurance. And then in 1962, they began to pay for doctors. And in Canada-wide, we had hospital insurance in 1957, and in 1968, we had Medicare, what we call Medicare in Canada, where doctors also were paid for. So the Canadian healthcare system was really built around hospitals and doctors, and those are the things that were largely funded. And a lot of that comes from the history. It comes from the fact that this was part of that early attempt to deal with acute infectious diseases and to primarily focus on the acute areas of illness. And that's what our healthcare system is like. So coverage was for hospitals, coverage was for doctors, and for not much else. The system became very fragmented as a result, and there were all these attempts to bring it together and to try to make it work better. And not many of them succeeded very much. So we still have a system that is structured around acute care and doctors and largely funds those activities. I think that the system then was built and the people in it were trained to do wonderful things to and for patients. And they also weren't trained at all to do very much with patients and families. And I think that that's probably the most important thing that we're trying to change now, is to recognize that that's the change that has to begin to happen, to work with people rather than simply do things, however wonderful they are, to and for them. There we go. Wow. So in Canada in 2012, we have a tremendous change in both the nature of the morbidity of the population and a change in the nature of diseases that people have. 2012, there was a world atlas of mortality and morbidity that was published by the World Health Organization. And this is some of the data from that. In Canada, 89% of the population dies of non-communicable diseases, of chronic diseases. Only 3% of people die of communicable diseases, and that includes people who die of AIDS, for example. Other people die of injuries. But the vast majority of people, almost 90% of the people who die in Canada, die of non-communicable diseases, of chronic conditions: heart disease, diabetes, lung disease, cancer. One of the things that happened in 2012 is that cancer became the leading cause of death ahead of heart disease. So we have a population that's no longer suffers from the diseases that really were the source of the healthcare system that we have. It also turns out that people over the age of 65, most people over the age of 65, in fact, almost all people over the age of 65 have one chronic disease or another. They take one pill or another. In fact, almost half the population of Canada is on long-term medication for long-term conditions. And also, among the people who suffer from these chronic conditions, about a third of them have more than one, which means that they have complex conditions, that the conditions aren't one disease, they're two diseases which may interact with each other, and the drugs can interact with them. And the big difference between acute infectious disease and chronic disease is that for acute conditions, patients and their families don't really have to be involved as much as they do with chronic conditions. So that shift means that we have to have a healthcare system where patients and their families can engage with the system and make that change. And that change is a very difficult one for a system that's based on an entirely different premise. I've spoken about this and go on. I'm not going to talk about this part. I think I'm going to go on from there and sort of say that the system, that it's really important to know that the system that we have is beginning to respond. I mean, the reason that this meeting is being held tonight is because it's widely recognized and recognized here that patients and families have to begin to engage with the system and have to begin to work with the system in partnership to begin to care for people who are suffering from these long-term conditions that are slowly developing and that happen over time. So continuity is important, and patient participation, patient and family participation is important in their care. And that's something that none of us is used to, something that's not part of the tradition, either for providers of care or for patients and their families. And we're beginning to learn to do that, and that's a big change that's in the process of happening. And some of the marks of that are that McGill University, for example, is starting to train family practitioners rather than specialists. It's emphasizing the training of family practitioners who are closer to patients and to the long-term process of care of those patients. That hospitals are beginning to introduce patient and family advisors as they are here. That what we're recognizing is that they're including partners in research at the Canadian Institute of Health Research, that there is more and more patient involvement in policy development and in the development of services throughout the healthcare system. So the Patients Association is connected to that, and what I'd like to spend the rest of my time with is introducing you to the Patients Association of Canada and what we do. The Patients Association started after I became a patient. I was in hospital for 2 weeks and saw many things that could be made better. My life was saved in the hospital, so they did wonderful things to me and for me. At the same time, they did very little with me, and there were lots of things that were very uncomfortable and quite unpleasant that happened to me and that are described in my book. And things that could be changed quite easily if patients and families were involved in the redesign or in thinking about how services were delivered in healthcare. I gathered a bunch of people around me who were also interested, and we began to gather patient stories, listen to patients and listen to what had happened to them, and listen to how easily things could be changed to make their experience better, to improve their experience. Our first partnership was with the Ontario Medical Association, where what we did was we began to help the Ontario Medical Association identify doctors who were especially patient-friendly. And so we collected nominations from patients, where patients would tell the stories about their doctors who were especially good, and we had an all-patient jury select doctors to be winners of the Patient Choice Award. And these awards have been given throughout Ontario over the last several years. We also began to work with healthcare organizations and to redesign and to think about redesigning services. So our mission, which is to engage patients and to make sure that patients are engaged in the healthcare system and work with it to make it better, is the main source of what we're doing. And we do this in a variety of ways. We think that patients' experience is the basis of all of these things. And we gather patients' experience through public meetings, which we hold quite regularly. We have the Patient's Choice Awards, and we're partners with various organizations in starting to use that experience. The kinds of services that we offer to various organizations is to review where they are, to see where they are with respect to becoming more patient-centered and to engaging patients in their activities. We also look at how organizations engage in this kind of partnership and what that means, and we help achieve these goals by looking at whether various policies and practices are instituted and looking at performance indicators of whether or not an organization is achieving this kind of partnership. And finally, we support both patients and staff in learning how to become more engaged with each other and how to form these partnerships that will allow the system to change. I'm going to say a little bit about key performance indicators and to explain a little bit about how what we do is audit hospitals and look at what particular policies and practices they have in place that show that they're patient-centered and show the extent to which they've engaged in this kind of partnership with patients. So we look at things like the extent to which they have patient and family advisors, the extent to which their policies are ones that are patient-friendly. We look at and we derive these indicators from the experiences that patients have already had. We take them from stories that come to us in a variety of ways. We gather these stories through, as I say, all of these various means and use them with a small group of advisors to develop these indicators that we use to audit organizations. And we support people through that process. I'll give you an example of some redesign that we've done, and perhaps this gives you a sense of it. At Baycrest, we looked very carefully at the process of redesigning admissions. And the particular thing that we looked at was the process of redesigning the day of moving into a long-term care facility. As you may all know, the process of moving relatives into a long-term care facility is a very, very anxiety-provoking day. It's a very difficult day. And it was very interesting to see that the process for doing this at Baycrest was not made easier by all of the different things that people had to do on the day of admission. They were required to move the furniture in. They were required to go to finance and arrange for payments. They were required to meet with the staff. So the day is a very busy day, and there is very little work done to reduce their anxiety, to make the day easier for them. The particular thing that we wanted to focus on was moving furniture in. And we found that the organization over a number of years had set up the rules for moving furniture in a way that was risk-averse, that didn't take into account their feelings, that didn't make it easier for them in any way. In fact, it made it quite difficult. So in order to move furniture into Baycrest at the time, the rules were that you had to call 3 days in advance to get an appointment at the loading dock, that once you were at the loading dock, Baycrest provided no help and no cart for moving the furniture, and you also had to use the freight elevator for moving the furniture. Moreover, Baycrest, because their lawyers advised them not to tell you, couldn't tell you the names of moving companies that could do the job for you. So we figured that was really easy to change. And we discovered that it took about 6 months to start to have the change, because Baycrest insisted on looking at the whole admissions process, having committees set up that met regularly, that this became part of a long bureaucratic process rather than doing things simply. When it finally happened, what happened was that the staff made the decision about what the changes should be, and the decisions that they took were that what should happen is that you only had to call one day in advance, and for $25 you could get somebody to help you. And that's sort of a very in-between notion. So what we did was we went back and made the final negotiations and they decided, and we accepted, that the way in which new people move in now is there is a special parking space for people who want to move furniture in, and that there will be a porter who will help them, and there will be no charge for that, and then they can do all of these things. And we've simplified the admissions process so that it's much less anxiety-provoking. But that could only be done with patient and family involvement. It could only be done because families and residents don't have the same culture as the providers who provide the care. And keeping those two separate and understanding that each has a role to play is part of the change that has to happen. We think that patients and family members can play various roles in the healthcare system. We think that they can serve as advisors to organizations to bring the patient and family perspective to the things that happen in the organization so that people understand what the impact of some of these things are, as Kim described. I think that those stories, and the story that Kim told us, is a story that's very significant in terms of helping us understand how things can change and what are the things that have to change in order to make the system much more patient-friendly. And those stories are absolutely necessary. We have to hear them, and we have to begin to understand what they mean and what we can do about them. We also think that patients and families can be mentors to others who are also going through the experience of being patients and families. So in the case of someone going through a particular piece of surgery, we've discovered that patients who have gone through that surgery before are probably the best advisors to people about how and what to expect, what the feelings are, and what the processes are, and what to do about them, and how to prepare for elective surgery. I think that this is a very important thing. And it's also important for people who are going to be family members to have other family members tell them what the experience is like and what things to look for and what to be careful about. So being mentors to other patients and families is a very critical role. And finally, we think also that patients should also be educators, that they can help train other patients to become patient and family advisors, but they can also help orient staff to the new way of looking at things and help by telling the kinds of stories that they tell, of preparing people for the kinds of changes that have to be made. We think that these are all important roles. Finally, we think that patients have a very important role to play in research. That in research, the kind of research that has been done has been very much body-oriented over a very long period of time. Recently, the Canadian Institute of Health Research began to change the research and introduce what they call patient-oriented research, which is research much more oriented to the patient as a person and to the family that related to the patient. And this kind of research, which is much more direct and much less focused on body and body parts and much more focused on the social circumstances and the other circumstances of patients, is the kind of change that we expect to happen. And the Patients Association is very much involved in all of these aspects of introducing patients and turning them into partners in the system. So you can all join the Patients Association. And the way to join is to go to our website, which is, I think, on the next page. Let me just see if I can get there. There it is. There. It's free. You just give us your email address and you become a member automatically, receive a very little bit of information. We don't intrude on you. But your voice will be added to ours in saying that patients must become partners in the healthcare system and must become participants in designing care, in policy development, in research, and in all aspects of the system. So thank you very much.
So welcome back from our intermission. I hope you had the time to go and visit the booths and talk to the vendors. And now let's continue with part 2.
So basically, when you're designing a more seniors-friendly healthcare system, you have to look at the system as a whole. All the various parts must work closer together so everyone knows what their options are and receive care in the quickest, smoothest manner possible. And as you've heard during the question and answer period, we've got a lot of work to do. I think the system is truly in transition. It's only started a few years ago, and I have a feeling it's going to take a while, but at least the transition has started.
Alors, durant cette partie de la soirée, on va mettre l'accent sur l'ensemble des parties du système de santé et comment ces différentes parties peuvent se concerter et travailler ensemble afin d'assurer que les personnes âgées et leurs soignants connaissent leurs options et reçoivent leurs soins de façon la plus rapide et la plus cohérente possible. Now, Dr. Zalan, I have a question for you, and I'll ask you in English so it'll be easier. If I were to ask you who you would choose to talk about how to make the hospital more senior-friendly, what would be your response?
Well, our next speaker, Dr. Janet MacElhenny. Thank you.
Voilà.
It's funny that you asked me that question. Actually, you may not know this, but we've got our two speakers here are both geriatricians, and up until a few years ago, we had 0 geriatricians. So just to show you that actually we are in transition, and definitely for the better, we have 2 leaders in geriatrics and seniors care that the rest of us really couldn't do. So I'm really excited. They're here in Sudbury, and they're actually here to talk to you. So we'll start with Janet, who's the medical lead for seniors care at HSN. She holds the HSN Voluntary Association Chair in Geriatric Research. She's also a senior scientist at the Advanced Medical Research Institute of Canada, which is the research arm of HSN. Her areas of expertise include the use of vaccines to promote good health and reduce frailty in seniors. And she's also researching how hospitals can lessen the risk of seniors becoming more frail once they're admitted to hospital, which is basically sounds like the research that's also being looked at and published in the New England Journal of Medicine that we've just heard about.
Alors, parmi ses nombreux champs d'expertise, Dr. MacElhenny étudie comment l'utilisation de vaccins peut promouvoir une bonne santé et réduire la fragilité des personnes âgées. Un autre de ses projets de recherche porte sur comment les hôpitaux peuvent réduire le risque de fragilité des personnes âgées une fois admis à l'hôpital. Dr. MacElhenny recently returned from a European health conference where she was keynote speaker, discussing the effectiveness of vaccines for improving seniors' health. Please help me in welcoming Dr. Janet MacElhenny.
So I want to tell you, because many of the questions that came up in the earlier part of this session actually speak to Louise, who was Dorothy's daughter. And the reason why she came forward with all of this is that before she retired, she had been second in command to the last person that you got to in the customer complaints department before you got to the VP for customer relations. And what she learned in that role was that how could you, when people called in, try and work with them to come up with a solution to their problem rather than trying to just keep pushing the complaint, and understood that partnerships were what it was all about. And so while we talk about advocacy, which I think is important, I think the other piece of it is that as one person asked, how do we sort of begin to work with the system to change what's actually happening? Because this not only makes a difference for that person in that moment, it also makes a difference for the next patient to come along. Because when we all as healthcare providers come to work every day wanting to make that difference in the lives of people. And when we find ways through working with families, it's something that can be repeated over and over again. So we started out with, so this is just to give you a little, I'm actually internationally known for these little stick figures to characterize older people, but it's just to say that back in the 1980s when I decided to go back to medical school to become a geriatrician after my experience as the housekeeper in the local community hospital. I was going to change the way we provided care to older people because I didn't want them languishing in beds on chronic care wards for the ends of their lives. And in the 1990s, that usual aging person that you heard referenced in the first talk tonight, who represents the most common person out there, that yellow stick figure, means that while we can be active and independent in the community, as we become 65, we are all at risk of having complications of some acute illness or chronic disease because we all have them. And so this is the way of managing health, and particularly through the crisis of a hospital admission. So when the presentation tonight is really focusing on most older people who are out there in the community and how we can support people through their hospital care, and to understand that the determinants of health in this population are not just the confidence in the physical health that we focus on a lot in hospital, to understand that people's competence or their decision-making abilities equally contribute to their outcomes, and that where we have people whose decision-making capacity may be compromised, especially in hospital, that we have other folks there that can help us with decision-making in the hospital setting. But also to understand that when you are there as families, you actually have as much to contribute to the healing environment just by your presence, because that connection is so important for people. And it's an environment that's fast-paced with constantly changing healthcare workers and everybody coming in. And you know, the look on the patient's face when you come in and you say, hello, I'm so-and-so, and it's another face that's come into the room. It's mind-boggling. So we're trying to find ways for teams to work together so that we all aren't seen as individuals. And this is the statistic that was quoted in my talk, is about the fact that, and this is what really got me going on this, if you figure that 1 in every 3 of seniors admitted to hospital is going to be discharged at a higher level of disability, surely there is something we can do to change that statistic. And this is a slide from Dr. Samir Sinha, who wrote the Ontario Senior Strategy. But this is just to show you. So this represents the 70-plus population. So which piece of that pie, for those of you who've never heard that talk, do you think are seniors that are high users of the hospital system with recurrent admissions to hospital? Is it this one, the 42%? How many are going to pick that one? Put your hands up. Okay, how many think it's this yellow one here? Some more. And this blue one here. And how about the green pie? Yeah, so this is the group that are the high users and the most frail people in terms of hospital use. And there needs to be different strategies, understanding what people's health was like before they went into hospital, and when people may become so frail that we have to be careful about offering all of the technology that modern hospitals can provide, because we have the risk of doing harm to people. And we're going to start looking at who we're actually offering surgery to and when there is the real possibility of harm happening to that person. And this is what happens, is that as we come into hospital, as we age, we tend to go down this slide But that can become very accelerated in times of acute illness, so that somebody who was a 4 or 5 in terms of being independent on a scale of 1 to 9, being healthy versus very frail, is that somebody through an acute illness can suddenly go from here down to here. And I think that that is what is so devastating for people, is to go through that change that quickly, and the real fear that they're going to end up in a nursing home after being in hospital. And that's the leading concern of people over the age of 65, is that death doesn't matter to them anymore. They are quite prepared for the end of their life. What they don't want to do is they don't want to become dependent. They're used to being active people, and so what we're trying to do with sort of facilitating what we can do in terms of preventative strategies in hospital is to hopefully get them home with the supports that they need. So understanding that if we can get them through a hospital admission without any decline, but when this decline does occur, to understand that's not a permanent state, we're going to try and get them back to their previous level of independence. So I just want to give you one example here. This is an 82-year-old woman who presents to the emergency department with a possible fracture from a fall while walking at her 3K a day walking club. And you see that healthcare provider comes over, all smiles. They know exactly what to do for that patient. They cast the hand and let her go home again. And this is just to show you that if this person had waited a few days, had not been able to cook for herself or do things, or had family in to support her while she had that cast on her wrist, it might be a week later that she actually came back looking like this. So this is picture that 82-year-old woman who presents to the ED with a possible fracture from a fall. And when we look at that individual, now all of a sudden we're just overwhelmed by the complexity of the situation, because that person isn't just somebody with a fracture. We think like this. And so we put them in a hospital bed, and we see them ending up becoming waiting placement in nursing home. And that little part in the white there is that we've lost the ability to see through what's going on. So we forgot about the fact that 1 week ago she was walking with her 3K a day walking club and didn't have the family support when she was sent home from emergency, or the support in the community to be able to make it through that. And so other complications happen as a result of this. So what we're trying to teach people to do, and so you saw that frail scale score that I put up there, well, that's actually a score of how independent you were before you came in. So I want everybody on stretchers in the emergency department with their frail scale score on of when before they got sick, so that we know what the goal is, okay? Because when older people become ill, and especially when they have multiple chronic diseases, they all look the same after they've been on a stretcher for 8, 12, and 24 hours. And so teaching healthcare workers to look behind this mask of frailty that comes on when you become ill. And this is the care pathway that we instituted and is being implemented in all of the hospitals in BC, and what we're doing here. So this is, in addition to managing the medical problems, is a focus on medication reconciliation and appropriateness, as Louise alluded to. Delirium and cognition, we pay attention to those as really an urgent thing to be managed. And getting people up. I'm talking about on the day of admission, no matter what it takes, because once that older person has been in bed for a day, potentially with a catheter in to manage a bladder problem, which they probably don't need, and they don't eat, if they don't eat within 24 hours of admission, they don't want to. And then after 48 hours, it becomes a battle to get them to get their appetite back. And then they start to develop swallowing problems. And so this whole sort of cycle of decline begins to occur. So we are implementing a team at Health Sciences North that is going to focus on this at the time of hospital admission, to make sure that we're screening those individuals that are at high risk for disability to prevent this from happening. And to understand that mobility is really our fifth vital sign. We want to be looking at this every day to see if their mobility is improving, and how do we get the team, the collaborative approach to care. Right now, nurses, physicians, physios, OTs, social workers all practice side by side in the hospital with very little information about what each other actually does. And care processes that start with the view to discharge on the day of admission. So what can we do to get that person closer to home every day that they're in hospital, rather than this scramble on the day that it's decided that they're going to be discharged and trying to figure out what services to put in. We're trying to adopt a much more preventative approach to care during the hospital admission. So this is really what we're after, is that to understand that most older people that come into hospital have chronic diseases that increase their risk for this happening, and to understand that our goal of care is to either prevent that decline or certainly view this as something that's reversible, even if that process of recovery continues after they go back out into the community. And we've even talked about that first 48 hours after discharge, if we could focus on these 5 things in addition to their continued management of the medical problems, that we could change outcomes. So when we're talking about holistic care, it integrates evidence with the person's goals and values. We want to optimize prevention strategy to maintain independence, and really looking at goals of care. What would it mean if the quality of life were the determinant of value in healthcare decision making, rather than some of the outcomes that we are looking at as the kind of benchmarks that we usually use, is that to how to move that forward and really develop that relationship with patients and their families. Thank you.
Jana, thank you for your insights. You'll have an opportunity to ask questions, but that's after Dr. Clark has spoken, and who will be speaking about care in the community.
J'aimerais partager avec vous la première fois que j'ai rencontré Dr. Joanne Clark. Autre que sa jeunesse, j'ai été tellement impressionnée par sa passion, son énergie et sa dévotion à la gériatrie. Depuis quelques années, je la rencontre souvent à des conférences, sur des comités, etc. Et elle continue à m'impressionner. Elle ne fait pas juste m'impressionner moi, mais évidemment plusieurs gens, et elle inspire les gens autour d'elle, non seulement par ses paroles, mais par ses gestes concrets. Dr. Clark est responsable des services gériatriques spécialisés du Nord-Est, et elle est en grande demande. J'ai assisté à plusieurs AGA où elle était la conférencière principale, et je pense que nous sommes très choyés et chanceux de l'avoir avec nous ici ce soir.
Okay. Okay. Dr. Clark is a consulting geriatrician at the Northeast Specialized Geriatric Services, funded by the Northeast LHIN and administered by the city of Greater Sudbury. She arrived in 2009, and she became Sudbury's, actually all of Northeastern Ontario's, first full-time practicing geriatrician. Her specialty is community-based medicine designed to improve the health and vitality of seniors while they're in the community. Please welcome Dr. Joanne Clark.
Merci, ça me fait vraiment plaisir d'être ici aujourd'hui. Pour deux raisons. Un, c'est parce que je peux parler à propos du sujet favori des personnes âgées, puis des modalités de prévenir la faiblesse. Puis l'autre, c'est parce que pour la première fois, moi puis Dr. MacElhenny, nous tenons debout ensemble, les deux gériatres, gériatres, du Nord-Est pour la première fois. Alors vraiment, je suis vraiment heureux d'être ici. I was just saying I'm very happy to be here for two reasons. Number one, I love, as Kim has said, this is one of the areas I love to speak about, but also I get to stand for the first time with another geriatrician here in Sudbury, and that makes me very, very happy. So I have the most complicated task this evening, if I could say, because I have to speak last, and thank you for bearing with me. I will not feel bad if you sneak out or fall asleep. My own mom is here and has told me bingo starts, she's taking my 87-year-old grandmother to around 10. So just a little bit about healthy aging, that if you're going out at 10, you're doing better than me. And I'm also talking about, I would say, the most complex aspect of, I don't know how you get more complicated than community-based geriatric care, really. The demographic imperative is, of course, we know the population is aging. You already heard tonight that around the turn of the century, your expected life expectancy was around 40 to 50 years of age. If you're born now, you can be expected to live to over 80. The largest growing segment of the population is the over 85 age group, right? And this is the challenge, is that we are growing. People over the age of 65, although only 14% of the population account for more than half or nearly half of all health and social care spending. We are set to double, their older population is set to double over the next 20 years, while the 85 plus population is set to quadruple. And Dr. Sinha, who is the author of the Senior Strategy, who you will hear mentioned at the beginning of this talk and as well at the end of this talk, reminded us the other night that the healthcare system was in fact developed when the average age of a Canadian was 27, if you can believe that. So we may not have planned properly, as you can imagine. Right now, we have over 1,500 pediatricians in Ontario, but only 125 geriatricians. And we haven't built a healthcare system that is really well adapted to complexity. Most of us in the healthcare industry cringe at complexity, the actual very thing that gives geriatricians energy, and where we like to roll up our sleeves. Complexity breeds a bit of fear. It's complicated. One thing impacts another. There are usually several issues. And we aren't probably well adapted to managing the conflicting aspects of chronic disease, ability, disability, and frailty. We also are going to have a decreased availability of family and caregivers. You've heard several times tonight of the importance of caregivers and family in patient care. In fact, they are probably one of the main, if only, reasons many of the older people I care for stay home or are able to stay home. And that ratio is shrinking. As the baby boomers move up through the demographic, we are going to have a larger portion of the population supported by a much smaller informal care base. And how are we going to manage that? What we need to remember is healthy seniors need less care. So that graph that Dr. MacElhenny showed you earlier about the highest users of the healthcare system, most seniors don't overuse the healthcare system, right? They don't need healthcare. It's chronic conditions and chronic disease that drive healthcare numbers. So we know that seniors with 3 or more chronic conditions have nearly 3 times the number of healthcare visits than those with no reported conditions. And while they only account for about 25% of the senior population, they account for over 40% of the healthcare use. So chronic disease burden is really the defining factor of healthcare use. Now, we know older persons accumulate chronic illness as they age, but that is not necessarily, just because you're aging doesn't mean you're necessarily accumulating chronic disease, if you understand what I'm saying. So, we know that the more chronic disease you have, the more disabilities you have, the more functional challenges you will have. But it's more than just chronic disease. So one of the things that we learn about in geriatrics is the concept of geriatric syndromes and frailty. So when we went to medical school and we did our training, and where many of us are trained in medical models of care, we learned that you get a disease, like pneumonia, which is a lung infection, for example. And when that happens, you get a number of symptoms. I don't know if you can read that, I can't. But anyways, it's shortness of breath, fever, you feel unwell, you might get muscle aches and pains, you can't breathe. You go to the hospital, we give you antibiotics, you get better. That's the medical disease model, right? Well, there's the concept of geriatric syndrome that we need to keep in mind when caring for older adults, where instead of having one disease, a multitude of symptoms, and one cure, what you end up having is a number of predisposing impairments or risk factors, like some mild cognitive impairment, some weakness, maybe some vision impairment, maybe a bit off balance, maybe a number of medications, maybe not lack of a caregiver, lack of care supports, and then you become delirious. So in order to treat that delirium, which is one of the things Dr. MacElhenny was talking about, you need to do many things. There's no magic wand, there's no antibiotics, there's no single switch fix. Instead, we need to optimize your vision. We need to formalize your supports. We need to check to see if your depression is optimized. We need to see if your chronic diseases are well optimized. Maybe you have too many medications. Maybe you've been lying in bed for a couple of weeks or days at home. Maybe we need to optimize all these different factors. And the thing is, geriatric syndromes are as prevalent as chronic disease, and up to 50% of people over 65 have at least one or more geriatric syndrome. They commonly occur with chronic disease. So more than 25% of older adults have at least one geriatric syndrome. They're strongly associated with functional decline and disability. In fact, they're more likely than a stroke to result in disability. These are things like incontinence, pressure ulcers, falls, frailty, cognitive impairment, where it's not usually one thing leading to it, but multiple different things that lead to that presentation. And in order to treat it, you need to address many factors. Having a geriatric syndrome is one of the top 3 predictors of why people can't go home. So impaired mobility, problems with continence, cognitive impairment. And in fact, in some studies, if you look at, this is the number of geriatric conditions that you have, what are your risks of being disabled? Well, if you have one geriatric syndrome, you're twice as likely to be as disabled. If you have 2, you're 3 times more likely to be disabled. And if you have over 3, so just think, if you have a little bit of cognitive impairment, if you're having trouble getting to the washroom on time and maybe some vision impairment, you're 6 times more likely to be disabled or have a disability or an impairment in your ability to care for yourself. Compare to the odds of having a disability of having a stroke, which is 3-fold. If you have diabetes, heart disease, cancer, you're 1 to 1.5 times more likely to have disability. So geriatric syndromes are big predictors of why people have disabilities or aren't able to care for themselves in their home. Do you know what the most potent predictor of new onset disability is? You might have gotten a sense from the presentations tonight. What is the single most likely, most potent predictor of having a new disability? Ending up in hospital. Your odds of becoming acutely disabled is 60 times higher. So that blows everything else out of the water. So this brings us to the conundrum. So this is honest, doc. If I'd have known I was going to live this long, I'd have taken better care of myself. And that begs to the question that, we don't become frail overnight unless you end up in hospital. And then you might become frail overnight. But generally speaking, the prediction of how well you are, how well you're aging, or how functional you are in the community is a large reflection of your health over many years. It's sometimes less likely a cause of something acute. But if it is a new acute change, as Dr. MacElhenny says, often we can get you back, right? There's reversibility. So how do we manage this? If your job is to keep someone independent in the community, the one disease model doesn't work, right? There are so many things that are going to contribute to whether you're functionally independent, to whether you're able to live independently in your home, that a one disease model won't work for this group. We need to understand and identify what are those factors? How are they accumulating into this presentation? What are the threats to your independence? Is it mobility? Is it medications? Is it lack of medications? Is it lack of caregiver support? It requires, here's a word, integration of medical and social aspects of care, right? We need strong primary care. It's essential to have strong primary care, to maintain health promotion, to keep you healthy throughout the ages, to help combine all the aspects of your care into one spot. We need to be enhancing physical activity. Exercise, you heard Dr. MacElhenny talk about the importance of mobility and exercise in the home. It is no less, in the hospital, it is no less important in the home. One of the next biggest predictors of a new onset disability is restricted mobility. So the less you use it, the more frail you're likely to become. It requires us to plan senior-friendly environments, to have proper nutrition, to have access to these physical activity, to proper nutrition. What are our transportation systems? What are our communities looking at? How do we encourage community supports and connections? And having those formal and informal supports are essential. So this is what we often think about as how to change the trajectory to long-term care. That your approaches at every aspect of your journey is going to be very different. So at the top of this triangle is the healthy elder population. Well, your approach at this point is going to be more primary care, prevention, increasing activity, staying active, healthy choices, vaccinations, all the sort of thing you would get from a strong primary care. Health promotion, health prevention, falls prevention, physical activity, healthy communities. But as you become more frail, that's when we need to start targeting and saying, what are the accumulating deficits? What are the challenges and threats to independence? Are we identifying them? Are we addressing them? What if you're starting to show up in the emergency department? How are we identifying what's actually going on? How are we not just casting your arm and sending you home, but thinking about all the things Dr. MacElhenny talked about? As anyone in the emergency department saying, well, how do you get food? How come you fell anyway? Is it because you're dehydrated because you can't get to water? Is it because your knee pain is so bad you can't stand? Is it because you lost your caregiver and now you're not able to manage as well? And that's why we have GEM programs, which is the emergency management geriatric specialist in the emergency department now to help identify those things and trigger the family doctor to say, okay, maybe we need to check up on these things. Maybe we need to access more specialized care. And what if you end up in hospital? What are the services we've put in place at that point? But you want to know what else is more important? Is how are all these people talking to each other? And how are we using the assessments we do at every step along the way? And how are we sharing that information? So that as in Dorothy's story, we say, haven't I said this story enough? Haven't I told my story enough? I saw a slide yesterday, which it was too late to put into the presentation, following the journey of an 85-year-old gentleman across the care, starting at home, to the emergency department, to the community services, to the outpatient programs, to long-term care, to CCAC, to community supports, and the average assessment, there was about 35 assessments along his journey. And I'll tell you folks, we're all asking the same questions, right? So how are we using that assessment to make our choices? And here's the thing, it's how are we having this discussion along the way? So we heard from Kim this evening about the discussion around goals of care. And when and how are we having the discussion around goals of care? Because that's going to change across this journey. My approach is not going to be so much about targeting longevity and how do I reduce mortality as we progress through this. It's going to be how do I optimize your functional independence? How do I optimize your quality of life? How do I make decisions that is more about symptom relief, functional independence, and less so about doing a bunch of investigations that may or may not change the outcome? And how do I have that conversation continually with you, with the care providers, and how do we share that information as a care community? So this is just a little bit about my program. We work, I'm going to skip through some of it. I mean, I work in what's called the Specialized Geriatric Services Program. So we tend to work, we're at Northeast Specialized Geriatric Services at the very kind of tip of that triangle. But so what our goals are to improve functional outcomes, reduce frailty, reduce functional decline, maintain independence in the home, but also to increase geriatric capacity and ability to provide this type of care throughout Northeastern Ontario. So we're a regional program. So we provide specialized geriatric assessment. We provide education, knowledge, and transfer, promoting best practices in geriatric care, and again, try to increase capacity, which is a way of meaning how do we get other communities to have this expertise as well? How do we all share this expertise? If there's only 125 geriatricians in Ontario, how do we spread that expertise to all the primary care, to the care providers, to the care workers, to the PSW who has more interaction with that patient or client than the physicians ever will, right? So this is, the ideal way a system works with the seniors and caregivers at the center. I think we'll all agree that that's really not how we currently work, but that's really the ideal, is that the seniors and caregivers are at the beginning and end and continuum of this, and that we work around their needs. What tends to happen is these folks go here, and then they come here, and then they go back here, and then they go here, and then they come back here, maybe go back there for a bit. So what we need to be doing is how do we create this system where we create that the center is patient care and caregiver care. Where we work in assisting primary care, we work in teaching and education in the primary care systems, long-term care, hospital care, and as well provide specialized geriatric care. And specialized geriatric services, so my program's predominantly community-based, but the programs that Dr. MacElhenny, for example, runs in the hospital is what we would consider also specialized geriatric care. So that's inpatient consultation, inpatient assessment. So this is all part of that continuum. So we have a team which we serve most of Northeastern Ontario, and we do most of our business in Sudbury area. But we share with many care providers. So we work among some of the 26 hospitals. We work very closely with CCAC. We work with the Northeast Mental Health Center, especially in the outreach areas where we provide assessments and recommendations. We do consultation with some long-term care facilities, and as well spend a lot of our times in retirement homes providing assessments. We do home visits, but we do not do primary care home visits, which was definitely a need identified. So we tend to be a physician-based assessment, although every person who comes into our program is seen by a geriatric assessor, a nurse, or an OT, or a PT, and then referred on to physician assessments and referred to the multidisciplinary team. And this is not unique. I can't see far enough to follow my own slide here, but this model is not unique to what is considered ideal geriatric care. So if you have a one disease, one approach model, then it's easy to have a physician come in, do his assessment, leave, or her assessment, to have the nurse come in, do it. But when you have a geriatric syndrome model, when you're looking at the complexity, you need a team approach. So you need to be working with OT, with PT, with social work. You need to be working with the caregiver. You need not only to be working with one another, you need to be working with your community teams, to be having the conversation with CCAC, to be having the conversation with the Alzheimer's Society, to be having the conversation with the personal support workers in the home, to say, how is this being accomplished? How are we doing this? Are we achieving our goals? Are we modifying what's actually the problem here? There are, let's see, what do I do after here? So the other models that you will see described in the literature that are taking getting more popular is the PATH model, which is a palliative care and therapeutic harmonization model, which means when we start to have discussions like Dr. MacElhenny mentioned around, are we going to pursue surgery? Are we going to do these interventions? Are we going to bring you into this acute care system? Why don't we spend a couple hours and talk with the care team and say, where are we? Let's assess your level of frailty. Let's assess if you have dementia. Let's assess what your outlook really looks like over the next 1 to 2 years. And is this how you want to be spending it? Do you want to be spending the next 3 to 4 to 5 months in and out of acute care doing these investigations? Or are we going to instead think of another approach, a comfort-based approach, a symptom-driven approach? And this is a type of approach that has been spearheaded in Halifax under Dr. Paige Morehouse, and the preliminary data has shown that it really does change people's decision makings. And people are tending not to choose many of the what we would call more aggressive interventions and more palliative, but not palliative in a, I'm going to pass away in the next week or so, but more a symptom-driven approach, which is what's important to me, the patient, not what disease am I managing, not what is my hemoglobin A1C level or my sugar level or what my cholesterol markers are, but what's really important to me at this point and how do I achieve those goals. So other things that are important is teaching and education. So we do provide education to several different groups. We have a care conference that we have every 2 years that hosts nursing, OT, PT, physician groups that will be coming up again in September to provide updated information on geriatric care. Dr. Sinha will be there. I believe Dr. MacElhenny might be there. Yeah, okay. Wasn't sure. All right. So many keynote speakers on new developments in geriatrics. We provide physician education. We host residents, nursing students. You'll be surprised to learn that geriatrics is not necessary in undergraduate curriculum. You'll be in medical school, sorry, to speak plainly, medical school, in nursing school, in OT, occupational therapist, physical therapist. Geriatrics is not a required topic. Can you believe that? Right? It's changing, but as of right now, it is not something that is formally addressed in most medical curriculums. So we do some of that as much as we can. When we first came here, we worked with several partners to develop a PGY3 Care of the Elderly program so that family docs could become expert, do a year of extra training in geriatrics. We've recently we're starting with a physician who works at North Bay, and we're partnering with North Bay on this, on how to develop a geriatric medicine certificate program. So it's really tough for family docs to retrain, right? Because in order to come back and retrain, they have to leave their practices and their patients and put all that time into it. So we said, well, what if we came up with 6 or 7 weeks of working with us and working with our team and put together a curriculum so they can refresh their geriatric skills, so they can get appreciation for the complexity, the resources, the approach to geriatric syndromes. So we've developed that, and will hopefully be accredited soon, and we're going to start that next week with one of the first family physicians. We've started to work with primary care. And we've already hosted 4 primary care teams to look at developing a more comprehensive dementia model of care. So we've worked with Linda Lee's model and George Heckman, who live down south, who have specialized this in a number of different primary care clinics. So they've brought it to northeastern Ontario now. We've started with 4 teams, and hopefully we can expand that to increase the knowledge base and expertise in primary care. And then, of course, we work closely with the geriatric programs, both at the several different hospitals. But what more do we need to do? Well, the senior strategy, which just came out this last year, highlighted several issues that need to be addressed in community-based care. These are some of the highlights. I think they will become as no shock to anyone who has been involved in this system. We need to increase home care. We need more exercise classes and falls prevention. We know one of the biggest risk factors for frailty and disability in the community, not with hospitalization, but is immobility. So how do you increase exercise and falls prevention, which is also one of the #1 predictors of new onset disability? Housing and supports. Do we have affordable housing? Do we have retirement homes that are accessible and affordable to seniors that provide extra care when you need it? If we don't have enough beds, are we making those services available into their home? How are we connecting every senior to a doctor? If anyone needs a primary care physician, it's this group, right? It's not, I had no problem getting my husband a doctor when we came here. He's a young guy, shows up once every half century to the doctor, right? No one minded getting him, but are we making sure that the people who really need the complex, frail older adults, are we making sure they have access to a primary care provider? Are we coordinating well? And this is, time and time again, how are we sharing the information? I have people who have no services show up at my office, and I'm the 7th assessment that week, and they've had nothing for ages, right? So how are we coordinating that? Do we all need to be involved at the same time? Do we? And if we are, can we just talk to each other? There's all this privacy barriers that we put up, but I think Dr. Sinha said it best, where we all just need to get over ourselves, right? And the patient wants us to share that information. That's the struggle. Hospital at home models, also, if the hospitalization process is so detrimental, can we bring the hospital to your home? And HSN has also said this is a model they're very much looking to explore in the future. All of us know bringing the hospital into the home is a much better idea than having someone bedridden in the hospital. The data shows that as well. How are we improving transitions of care? Some of the best models we have of once people leave hospital to get them to not come back to hospital again, we have these excellent models, but they don't work if no one sees their family doc in that first week upon discharge, right? And who's communicating the information to the family physician? How are we ensure they're in the loop? How are we having improved training in geriatrics, and then again, the strengthening the PSW workforce, right? So everyone is saying this is the people who actually come into my home. Are they enough of them? Do we have CCAC that can provide these services, but do we have the human resources with which to deliver? Are we paying them enough? These are the people who provide hand-to-hand direct care to the frail, complex, older elderly. We pay them terribly, right? And they don't have a lot of training. And I don't mean that in a way, but these are the most difficult patients at times to manage, the people with advanced dementia, the people who are bedridden. How are we training them? How are we empowering them to say, there's a problem here, I'm gonna call the family doctor, I'm gonna call the caregiver. How are we including them in our care plan? So we can do a lot to make our community healthcare system more senior friendly. I think the ones I just mentioned are probably the most important. I don't have the solutions today, obviously, but I think that the Sinha report, and I think that at the next Senior Summit, we will have the honor and pleasure of listening to Dr. Sinha talk about some of these strategies. I think they highlight, I think they're right on in terms of what we need to do and what we need to address. I think the how is a lot harder, right? And the when and how fast, harder, but I think there's hope.
Merci beaucoup, Dr. Clark.
As our final speaker, I'd like to introduce Dr. Denis Roy, President and CEO of Health Sciences North. But just before I do that, I'd just like to say that I've been very impressed with his focus on seniors' care since he's come to our hospital. So I have a few examples. Under his leadership, we're introducing the transitional program, which is to focus on the highest need patients when they first go home for the first 90 days to make sure that everything that they need to be able to live at home is taken care of. There's also we're in the process of establishing an outpatient center of care for complex patients who actually have no primary care physician. Unfortunately, this does happen. And finally, recruiting Dr. MacElhenny, which I think has been a wonderful addition to our hospital. And finally, we're also working on introducing the PATH program that Dr. Clark referred to. So with those remarks, Dr. Roy.
Thank you, Dr. Zalan. Bonsoir. Good evening. J'espère que vous avez tous aimé la soirée, le forum public d'aujourd'hui ainsi que le salon des personnes âgées. On behalf of all of us here this evening, we want to extend our great appreciation for tonight's speakers, Kim Fahner, Sholom Glouberman has left, I guess, to take an earlier flight. Janet MacElhenny, Dr. Joanne Clark. I want to thank our two MCs, Dr. Peter Zalan and Kim Norris, for their excellent job. Je remercie également les commanditaires, les fournisseurs, les bénévoles, Dan Lessard et le service de communication d'Horizon Santé-Nord qui, ensemble, ont fait de cette soirée une belle réussite. Most of all, I want to thank you for being here tonight and sharing your input. What we heard tonight from our guest speakers and from you will definitely guide us in making the healthcare system more senior-friendly. Nous avons écouté, nous continuerons de le faire. Nous qui travaillons dans le domaine des soins de santé continuerons à agir et à réagir. C'est notre devoir. That is what makes evenings such as this one so important. We need your input. Your voice is essential in designing a healthcare system that will better meet your needs. One too often forgets that the system belongs to you and the population, not the physicians, not the managers, not the politicians, not the professionals, you. Une tâche si énorme est uniquement réalisable si les citoyens et les acteurs du système de santé collaborent. Tonight's forum is a wonderful example of this collaboration. We've already started to make the system more responsive to you. Les membres de notre conseil consultatif et du président directeur général, des patients et des familles nous guident en nous indiquant ce qui est essentiel afin d'améliorer le fonctionnement du système au profit des personnes âgées et de leurs familles. HSN is working closely with the LIN, the Northeast Community Care Access Center, or CCAC, and other community partners to ensure elderly patients receive the right care in the right place at the right time. And by combining our resources and coordinating our efforts, we have begun to create a system that moves healthcare for seniors beyond the walls of the hospital. Seniors tell us that they want to remain in their own homes as long as they can. New technologies and new innovations, and I'm afraid to ask Lionel to name a few because we're going to be here tomorrow morning. So new technologies and new innovations are making that possible. We are placing a great emphasis on seniors' health. A comprehensive approach to health touches the body, the mind, and the human spirit. But we recognize that there remains much more to do. En participant aux échanges de ce soir, vous nous aidez à construire un meilleur système de soins de santé. Ce faisant, vous vous aidez, ainsi que vous aidez vos proches qui sont des personnes âgées. Aging is inevitable, but it's not a disease. But at some point, all of us will need the healthcare system. If one is going to need the healthcare system, it only makes sense to play an active role in its design. That is what you are doing by being here tonight and by sharing your insights. Je vous remercie de votre présence, de votre collaboration, et je vous souhaite une bonne nuit. Merci beaucoup.
Just a couple last words, please. On voudrait remercier tous les commanditaires qui sont ici et qui ont pu faire arriver cette soirée. So a special thanks to our sponsors for tonight's event. Near and dear to my heart, Collège Boréal. HSN Foundation, who's also co-presenter. And all the vendors and exhibitors, thank you very much for your support and for being here. Very special thanks, I think we need to mention it again, to Health Sciences North Horizon Santé-Nord and the HSN Foundation for making this type of event being able to happen. Alors, merci beaucoup, thank you. Special note, first of all, there are evaluation forms. Please fill out your evaluations form and leave them at the entrance. S'il vous plaît, remplir vos évaluations, c'est très, très, très important pour nous. And mark in your calendars the next forum, September 19th, where we will be having Dr. Samir Sinha come in and, oops, I was supposed to say that one in French, sorry. Dr. Samir Sinha is going to be here le 19 septembre, September 19th. Thank you, merci tout le monde, bonne soirée, have a good evening.